tonight's event will be going to charities who wrote Hearts, which we'll hear a little bit more about later on this evening, and also to Drug Science UK. Really appreciate your decisions that led you to this event this evening. So I'm Dr. Angela Service, and I'm a GP and the owner of Eden Clinic, and been sponsoring this event this evening. Some of you will know Eden Clinic actually started life as an aesthetics practice, very much community. But after leaving the army a few years ago, I let my other medical interest run wild. I'm now offer quite a few different treatments, including testosterone replacement therapy, private GP appointments, blood tests, and my interest also led me to addiction management services for alcohol and opiates as well. Having spent years in the army as a doctor and worked in acute hospital settings as well, it developed my interest in the area of addiction management services. Like quite a few of you here this evening, I probably sort of saw firsthand the way that some of the services available don't necessarily fit every person who has issues with PTSD, with trauma, management, and with addiction. And that's what led me actually to unveil this course. And sort of prompted my interest here. And really got me interested in psychedelics and medical medicine. So eventually, I sort of hatched a bit of a plan to bring all the brightest minds in the UK here in Plymouth to be able to deliver their wisdom to us, so we might be a little bit inspired to share some of the information that we learned about this evening. So really genuinely am chuffed to have got the speakers that we have here this evening. Particularly, we're really blessed to have Professor David Nutley here, who essentially is a much more useful equivalent of David Attenborough. Well, can you say that? No, we're going to talk about later. Yes. But I think my hope for this evening is that we all leave with something to talk about with a friend, something to share with a friend, a relative, maybe an opinion or a view that has been slightly changed, and a little bit of inspiration in an area of medical research which is really challenging, but also. So, without further ado, I am delighted to introduce our compound MC for the evening, Professor Jo Neal. She is a professor of psychopharmacology. I had to practice saying that several times before getting out. So, and she's been a drug researcher, dedicated more than 30 years exploring medicines for mental health. Jo also holds the role as chair for the Medical Psychedelics Working Group at Drug Science as well, where she focuses on enabling the psychedelic medicine to be integrated into mainstream psychiatry and healthcare. And her work also involves very much advocating for evidence-based drug law reform. Genuinely couldn't think of a better guide for us for this evening's the presentation delivery. So, Jo, that is over to you.
Yeah. Thank you, Angela. So this came out of a conversation Angela and I had probably a year and a half ago. And I'm so grateful to Angela and the Eden Clinic. We all are for organising what's going to be an absolutely cracking evening. Lots and lots of learning, but we have, as she said, the world experts in the area of psychedelic medicine. So it's a real privilege for me to be the MC. I think it's the first time I've been called an MC. Very exciting. I'm also chair of trustees for Drug Science and a trustee for Heroic Hearts Project UK. So I work closely with both organisations and absolutely love the work that they are doing. Pretty much both saving lives. So thank you all so much for coming, and your ticket sales are going to support both these phenomenal organisations. If you've got any spare money, it is possible to donate more using the QR codes at the front and attached to your tickets. So really, I haven't got much to say to you just about the format. So we're going to have quite short talks, which is a wee bit unusual in this space, but we wanted to have a really good time at the end for a panel discussion. So all your questions we'll cover. There are a lot of you here actually, but people have so many questions about this topic, which is great. But hopefully we'll be able to get to your questions, and then we'll move into a more informal situation, and you can talk to the speakers directly, which people always have loads of questions. So the talks are about 20 minutes, and we'll have 3 talks before the break at about 8:30. And what I thought some people have absolutely burning questions for that particular speaker. So I thought we'd do 1 or 2 questions from the audience after each speaker. But mainly, we'll do all the Q&A at the end. I think it'll work very well. Okay, so that's enough from me. And it is my pleasure to introduce Professor David Nutt, who I think needs little introduction to most people, being as famous as he is. But a little bit about him. He holds the Edmund Safra Professor of Neuropsychopharmacology. His titles are very long. He's at Imperial College in London, and he's director of the Psychedelic Research Unit there. He's been president of most brain science societies, including the British Association of Psychopharmacology, where both of them worked a lot for them. He's the founder of Drug Science, the former chair of the Advisory Council on the Misuse of Drugs. He's won most brain science awards. And something you may not know is that he was awarded a blue at Cambridge for badminton. So, great sportsman as well. Absolutely committed, totally committed to evidence-based drugs policy and research into the medical benefits of currently illegal drugs. He is a man with extraordinary abilities, force of nature, so much energy, commitment, and the original gangster of psychedelic medicine. He's incredibly brave. He's also very, very compassionate, kind, and above all, he's great crack, as we'd say in Northern Ireland. So over to you, Professor Lemon.
Is this one on? Probably not. Thank you, Joe. Yes, boy, what I give to be able to even hold a badminton racket. So my talk is about how psychedelics work. How many of you have read my book? How many of you have brought it to sign? Good. You get the first question. The other book is a more recent book, but it's very dense and intense, and you should only read it if you can persuade your university or organization to get it. But it is a bit more up to date than the one I know. So we've learned a lot about psychedelics in the last 20 years. And the first thing we learned is that the myth that they were harmful has been completely demolished. And it's been demolished by a series of analyses using the most sophisticated technologies we have in terms of decision-making called multi-criteria decision analysis. And I suppose most of you will have seen this image at the bottom left here. That does work. That is, was published and announced in 2010, the scale of harms. And it shows it on the left-hand side here, alcohol is the most harmful drug in the UK. And over here in the red circle, you've got psychedelics. And they're much, much less harmful than alcohol and other drugs like heroin and crack. And this must be true, because Elon Musk has been telling everybody this. And that's so he can use ketamine, which is less fun. It's been replicated by European experts, by Australian experts, by New Zealand experts, and soon to be published by Canadian experts. So we all agree, if you read the evidence for the harms of these psychedelics, even when they are used recreationally, the harms are vanishing visibly. And when they use once or twice in clinical settings, the harms are virtually non-existent, and certainly comparable or less than any other medicines we might be using. So the lies that they were dangerous, those have been dissolved. And I don't know. Okay, well, this unfortunately we've lost a few images from this, but I can talk you through it. Probably the ones at the bottom are more interesting anyway than the graph. When these drugs were banned in the 1971 UN conventions, they were put into Schedule 1 as highly dangerous, very addictive, and had no medical use. They were shown they're not highly dangerous. At the time, they were known not to be addictive because there were 6 studies showing that LSD could be used to treat alcohol dependence. And there were 40,000 patients had been studied, and there was a lot of evidence of good medical use. And they were rebanned because they were changing culture, they were changing art, they were changing music, and they were associated with the anti-Vietnam War peace movement. And the Americans couldn't ban anti-war protests, so there were other governments are trying to do that, including our own now. But they could ban the drugs that they thought were fueling the protests. So these drugs were banned. And they were banned from medicine in a deliberate, malicious attempt, I think, to prevent anyone ever using them again, because they were seen as too basically banned. But luckily, we've been fighting back, and we now know that they have both medical use. And our particular interest is the fact that we are, well, in a few weeks, we're starting the first ever study in the world of psilocybin for heroin addiction. So, They are medicines, they were medicines. How do they work? Well, they work on a receptor called the serotonin 5-HT2A receptor. They stimulate that receptor, and their affinity, their stickiness to that receptor, determines their dose. Drugs which are very potent, very low doses like LSD are very sticky, and drugs like mescaline are much less sticky. But there's a strong relationship between the affinity at this receptor and what they do, and what the clinical dose is. And that tells us they all work through that receptor. And we know the receptor structure, and we know where they work. This is the 5-HT2A receptor. These are the intracellular components which turn the binding of the psychedelic into an effectiveness. They're all somewhat similar to serotonin. They all act like serotonin does on this 2A receptor. And what's interesting also is that the number of medicines we have, which we use for psychosis and depression, like mirtazapine, risperidone, they block this receptor. And that's of clinical importance because it means that when we're treating people, we have to make sure we can get an effect. We have to stop these medicines if we want to have the full psychedelic effect. Now, what's really interesting about these serotonin 2A receptors is that they hold a very special place in the human brain. So on the left-hand side here, you see what's called a PET scan. It's an image of the human brain where the 2A receptors have been labeled by a tracer called 736. And you'll see that this is called a heat map. The hotter the region, the more of the receptors there are. So these regions, the frontal part of the brain here and the posterior part of the brain here, have highest density of these receptors. There's the lower levels in sensory motor script and individual cortex, and very low levels in other parts of the brain, those parts of the brain which control cardiovascular activity and respiration. And these drugs are very, very safe because they don't affect core physiological processes that keep you alive. In fact, it turns out these receptors are particularly expressed in the most recently evolved parts of the human brain, as shown on the right-hand side here. So this is a heat map of human brain evolution. And you can see that the redder bits are the most recently evolved parts of the human brain. And there's this fascinating overlap between the 2A receptor and these most recently evolved parts of the brain. These recently evolved parts of the brain are the parts of the brain in which we do the peculiarly powerful human things we do, which is thinking and feeling and planning and anticipation and reflection, etc. This is where the human consciousness resides. It's called the transmodal cortex, and it separates us from other primates and other species. We're not entirely sure whether there's a strict relationship between these receptors and the evolution of the brain. Some people think there is. It's hard to prove. We wrote a paper last year suggesting that these receptors may have an important role in how the human brain actually forms its full functional capacity. That's still hypothetical. But what is absolutely clear is that psychedelics work on the bits of your brain which define you as human. And that is why they change the way you think. And that's why they can change the way you understand many different aspects of yourself and other elements of life. The third one we have learned is that Aldous Huxley, when he took mescaline and wrote about it in this book, The Doors of Perception, it was right. He explained the experience of a psychedelic trip on mescaline as his mind being freed. And his interpretation of that was that something was constraining his mind. And reflection, he came to the view that his brain was controlling his mind, limiting his mind. He said his brain was a reducing valve. It stopped his brain achieving its full capacity. And he introduced the concept of the mind at large, a mind freed from the constraints of the brain, which of course is something that many people experience during psychedelics. And we now understand how the mind is liberated. And it's liberated because psychedelics change the connectivity of the brain. These are images that show the effects of very series of different drugs on electrical activity in the brain, measured using this technique called MEG, which is like a sophisticated EEG. So these are brain waves, basically. On the right-hand side here in the red box, you see ketamine, what's the other side of LSD. And as in the other images I showed you, blue is less. And what we are measuring here in these different frequencies is the power of the brain wave in these different frequencies. And these three drugs, these three psychedelics, reduce the power in those frequencies. So they're exactly opposite of drugs that sedate you or anesthetize you, or in the case of alcohol, get you drunk. Psychedelics produce a state of desynchronization of brain activity we call the entropic brain. And that is why your brain can no longer control your mind. Your mind can then do things it wasn't been able to do for some time. And this is becoming really quite challenging because now I've lost my best image. Okay, but you've probably all seen it. It's two circles with lots of connections. And on one side, the connections are very much around the edge, and that's got the whole brain. On the other side, the connections are across the brain, and that is the hyperconnectivity that you see under a psychedelic. And this is an image of someone with depression. And depression is called depression because it's as if your thoughts are in a deep trough out of which you cannot get. And what psychedelics do is disrupt the landscape of the brain so that people can get out of the trough and think differently. And this is an image of the hyperconnectivity of the brain we see with LSD. So there's other images. That last image, which you didn't see, was psilocybin. This is a similar one in the data. And it shows the profound hyperconnectivity of the brain. This is connectivity of the brain to the visual system, the visual cortex. Normally, your visual system is very limited in how it interacts with the rest of your brain. Very efficient, but you don't see visions. No way. Under psychedelics, you see visions because your visual system is the enter of your brain. And that massive increase in connectivity gives people insights as well as visions. And as a result of that changing connectivity in the brain, we noted 15 years ago that a network in the brain called the default mode network, which controls the nature of thinking in humans, was disrupted by psilocybin. And based on that, we thought maybe we could disrupt depressive thinking because that is encoded in the same network. And so we did this first ever study of psilocybin for depression. We gave individuals who had depression that had not responded to at least 2 separate treatments and have not responded to 10 different treatments. They'd all had C to T. And you can see the single dose of psilocybin produces a profound and almost immediate reduction in depression scores that lasted for months. And this is the most powerful single intervention treatment-resistant depression has ever been. And it spawned a whole series of other companies setting up to do research with psilocybin and other psychedelic analogs to replicate this. And they're beginning to. And when we analyze these data using a modern technique called Bayesian analysis, we can predict that if we were to put another patient into this study, there's a likelihood of about 80% that they're going to get better. It's truly remarkable for any kind of intervention in psychiatry or medicine generally. It's been replicated in studies in the US, studies around Europe, and also with other drugs like ayahuasca. We're pretty confident that psychedelics, particularly psilocybin, powerfully lift depressive ideation. What's particularly interesting is they do it they produce psychedelic changes in everyone. But the particular subjective experiences, the experiential part of the trip seems to be relevant for the outcome. And this is a spider plot. The blue outline are the individuals who did very well in the trial. The red ones who didn't do quite as well. And the ones who did particularly well had greater experiences of unity, spiritual insights, a blissful state, and general insightfulness. These we call the peak experience. So the quality of the experience under psilocybin seems to predict the clinical benefit. And that has now been replicated by the Native Big Compass Pathways trial, but also in our more subsequent study using psilocybin, comparing it to the SSRI, the citalopram. So it's not just disturbing the brain, it's also disturbing the brain and giving people insights into why they have depression in the first place and how they can view themselves as being undepressed. Those powerful subjective experiences of enjoying learning. And this is still the only head-to-head study between psilocybin and an SSRI, which we conducted, and it shows that psilocybin in red outperforms SSRI, the citalopram, both in terms of reducing depression scores, and particularly in improving well-being. And we think this may well be one of the great benefits of psychedelics is that they're producing enduring improvements in well-being, which can give you resilience to future episodes of depression. That's maybe why a single psilocybin treatment, as it has done in some of our patients who were treated 12 years ago, was kept them well all that time. And we've also learned that there are changes in the brain of connectivity which endure after the treatment. This is data from the citalopram trial showing that flexibility in the brain, reduced stiffness, reduced modularity of the brain is present 3 weeks after psilocybin trip and predicts clinical outcome and predicts increased cognitive flexibility by allowing different networks in the brain to talk to each other more easily. These changes in flexibility do not occur with an SSRI. So this tells us that what psychedelics are doing is not simply getting people better faster, but it's getting people better in a different way, which is highly exciting. And in that particular study, we also explored why or how escitalopram works. It turns out that escitalopram works to blunt the stress centers of the brain, the amygdala and the limbic system. And that is why escitalopram or acetyl lift depression. But the cost of that is that for many individuals, they also blunt pleasure. And we can see this, the blunted response to happy faces in the escitalopram group, whereas psilocybin didn't indeed were either negative or positive responses, images that were being projected. So this is a fundamental difference between these drugs. And just to finish, we've also done some exploratory work on whether we can use a non-psychedelic dose, a 10 milligram dose of psilocybin, a psychedelic dose, in patients with OCD. Why did we? Because it told us categorically they would not at a trip. They didn't want to run the risk of losing control, even if it would help their OCD, which we thought it could. But we compromised and we gave a placebo dose and a 10 milligram dose, which they perceived as having some effects on their brain and their ability to think clearly. And it did. It reduced, for a couple of weeks, it reduced compulsions, and for a week, it reduced obsessions. And we're now working to try to develop a plan to pursue this, because we think maybe if we gave this perhaps every 2 weeks for a couple of months, we might get bigger and more enduring outcomes. And we know that psychedelics now can treat a whole range of disorders, not just depression, but generalized anxiety disorder, addiction, anorexia, etc. And you might say that doesn't make any sense at all, because they're all different disorders. They've got different diagnoses. But they're all internalizing disorders. They're all disorders in which people thinking gets locked into the ruts, out of which they can't escape. And psychedelics disrupt the ruts. They break rumination, and they allow people to think differently, which is what you need to do. So not to be depressed or anxious or addicted. And I want to just a few words about MDMA, because we're going to be talking about war trauma as well. And MDMA has now been resurrected from being 20 years ago, it was seen as something that damaged the brain. Now we see it as something that can heal the brain. There's no question the Afghan and the Iraqi wars led to this resurrection, where we have enormous trauma in both the military population and also the civilian population. And many of you will be aware there have been 2 major studies of individuals with PTSD. The MAP study over here, this is the first one, the subsequent one was very similar. Powerful therapeutic benefits of 3 doses of MDMA in people with severe PTSD, dramatically improving outcomes. This is a small study we did in Bristol, using MDMA, 2 doses of MDMA in people who detoxify from alcohol dependence. And we showed the ones who'd had 2 MDMA sessions in this period of abstinence had much, much less likelihood of relapsing than the ones who hadn't had the MDMA therapy. So we've got evidence of MDMA for PTSD, for addiction. And the theoretical basis of that is shown on this slide. This is the brain image of what happens if you take MDMA, and you see it's blue. And blue means less activity. And again, it was rather surprising to us that MDMA, which many of you will have used and have had the experience of being able to dance and bounce around all night, you'd be surprised to find that the primary effect of MDMA is to dampen down the limbic system, the stress system. And this, we believe, is why it helps people deal with trauma. Because when this system is dampened down, people can relive the trauma and develop cognitive strategies to overcome the trauma and recover from it. So that's described in this little editorial of ours. And I want to say one other thing. There's a terrible temptation by people who are anti this field to use terms like hallucinogen, which I don't want ever to hear anyone say. They use it in a pejorative way, just like psychedelics. And they use amphetamine in a pejorative way for MDMA. And MDMA might have a structure that is somewhat similar to amphetamine, but it is not an amphetamine. MDMA is a serotonin releaser. Amphetamines are noradrenaline and dopamine releases. So the pharmacologies are very different. So I'm going to finish with this wonderful quote from George Bernard Shaw: those who cannot change their minds cannot change anything. That is absolutely true about patients. If they cannot change their brains, they cannot change their minds. And they want to change their minds. And these data that I've shown you have changed the minds in countries like Australia, which in almost 2 years now has had both psilocybin for treatment-resistant depression and MDMA for treatment-resistant PTSD available for doctors. Just a couple of weeks ago, the German regulators approved compassionate use for psilocybin in Germany. The Czech Republic are going to do the same at the end of the year. There's also been a movement in Canada to allow compassionate use. So other countries are moving. And they're moving because they know the data is very strong. They know the drugs are very safe. And they don't want to wait until a drug company comes along and sells the drug to them. because the drug companies might never come and sell the drugs. And waiting forever is rather too long for most patients. So we are now beginning to develop a campaign in the UK to try to get us to move with those countries, particularly Australia, where we've got really good evidence of efficacy, essentially. And one of the things we're doing, and I want to, if any of you are interested, particularly medical professionals, doctors, therapists, etc., take a picture of this or to get me afterwards. We'd like you to sign up to Psychedelic Action. We've now got 7 professors of psychiatry, nearly 100 of the doctors signed up with it to this campaign, which we're going to be lobbying over the next 2 years to allow access of psilocybin and other psychedelics and MDMA to patients in this country because they deserve it. And there's absolutely no reason whatsoever why they shouldn't have it. I'll stop now, and thanks again for listening. If you want to read more, there's some books, and I'll be here to answer questions until you kick us out. Thank you.
Very much. That was fantastic. Every time I hear Dave speak, I learn an awful lot more. Absolutely brilliant. I think we've all got the power actually to change the law. It's about having those conversations, telling your parents, your grandparents, your children what an important innovation in treatment this is, and how difficult it is for people to want to access it. It's not possible in this country legally. People have to go abroad. You'll hear from the veterans. You know, that's so wrong that people fight in this country, or, you know, they belong to this country and they can't access the medicine that they know can heal them. So I do think it's up to all of us to kind of spread the word. And I've got brilliant conversations with people in trainings and all sorts of places like this. I think in the interest of time, you're going to move on to the next speaker. Now, the next speaker is somebody I've not heard speak before. I can't believe how that's happened. So I'm really, really excited to hear him speak. I live now in Swanage in Dorset, which is very much standing out in beauty. I'm in nature a lot, but the impact of psychedelics and connecting us to nature is something else again. I'm so excited to hear this. So Dr. Simon Yadidi, he's a PhD ecologist. He's an independent researcher. He's a science communicator, so we're in for a big treat. He has a lifelong love of nature, and his work has spanned the ecological and the psychedelic fields, which is pretty rare for people who's found these very large fields. His work as an independent researcher has involved a number of collaborations with a lot of academics, a lot of different institutions.
Thank you, Joe. Yeah, it's great to be here among proper 3 trio professors. I'm not an A-lister academic. I'm a hobbyist academic, really. So it's nice to be kind of moving in such circles. As Joe mentioned, my sort of primary research interest is the capacity of psychedelic substances to shift the human relationship with nature, because that has a number of important implications. So before I sort of go into more detail about this, I think it's good to define nature connectedness, or nature relatedness, or nature connection, as it's been variously termed. And that's essentially a personal relationship with nature that a person might have. So it's being defined as a realization of our shared place in nature, how we experience the world here and now, our emotional response, beliefs, and attitudes towards nature. And that's made up by elements of our cognition, our emotions, and our direct experience of the natural world. Unfortunately, this connection is being increasingly eroded through a number of societal, psychological, and lifestyle factors. And unfortunately, Britain is bottom of the league table of assessed countries in Europe for our average connection to nature. And these various interacting factors are leading to what's been termed an extinction experience, so diminished capacity for everyday interactions with nature. Also, unfortunately, we're also considered one of the most nature-depleted parts of the world, the British Isles. So we're not only ecologically impoverished, but arguably psychologically and maybe spiritually impoverished as well. And this should concern us, because this connection to nature is fundamental, really, to our capacity to flourish as beings. And so some of the research that's been done, so this figure is taken from the blog of a leading professor who heads the Nature Connectedness Research Group at the University of Derby. And what's interesting about this study, looking at different aspects of people's relationship with nature, was that it found that nature connectedness had 4 times the predictive power, predicting people's eudaimonic well-being. So that's a form of well-being tied to life meaning. 4 times the power of socioeconomic status, which is usually fairly reliable sort of predictor of baseline well-being. This aside, it's also been linked to happiness indicators. So one study reporting, again, similar effect size to social factors such as income and education. But this aside, it's been tied to psychological resilience and restoration, and also importantly, emotional regulation. So people who have a deeper connection to nature, it's like they can tap into a fund of calm, which can be mentally supportive. Nature connectedness as well also acts as a mediator for some of the benefits to cognition and mood obtained through spending time in nature. And it also predicts the propensity to want to spend time in nature, which is itself important. Nature connectedness as well as having these mental health benefits is also a key predictor of pro-nature attitudes, awareness and behaviors, which is quite topical given that we are in a mass extinction event that our species is currently orchestrating. So just considering some of the work that's been done, there's been a variety of kind of survey studies showing a link between total lifetime usage of psychedelics and people's baseline level of nature relatedness. And then a few smaller prospective studies that are a bit more rigorous, showing that psilocybin can potentially enhance levels of nature relatedness, even when used in a kind of a clinical, non-nature enriched context. There's also been some research, not nearly as much, but some on ayahuasca, showing that ayahuasca can enhance nature relatedness and appreciation for nature. And some of the work that I've been involved in, it was interesting to note that it was hard to pinpoint exactly what was giving rise to this. Was it the ayahuasca itself? Was it the biodiverse Amazonian rainforest habitat? Was it the enforced digital detox that was necessary, or the shamanic context as well? So further work's needed to pick apart what's contributing there. So this figure came out of a survey study collaboration with the Centre for Psychedelic Research at Imperial. And this was looking at total lifetime experiences of psychedelics and people's mean nature relatedness. And you can see we've got a very, very clear relationship between the number of experiences and people's nature relatedness. And this all also correlates strongly with well-being levels. Sort of building on this part of work, I was kind of curious as to whether the type of psychedelic might influence nature relatedness. So I kind of looked up a number of academics I knew that had data sets looking at this, and we sort of pulled these 5 individual data sets and crunched the numbers. And interestingly, found that only past use of psilocybin emerged as a reliable positive predictor of nature relatedness. And this applies to psychedelic naive people who've never taken a psychedelic before, or those who solely had used psilocybin. And this wasn't simply down to motivations or the context or setting that people were using these things in. As to why that's the case, not really sure. That requires further work. So this figure here is slightly controversial because this hasn't been submitted to, it is imminently being submitted, but it hasn't passed through peer review. So taking a small pinch of salt. But what's quite exciting, this comes from, again, a collaboration with Imperial. So the top graph there is coming out of a clinical sample with people having psilocybin therapy for major depression. The bottom one is coming out of the INSIGHT study, which is where psilocybin is being administered to healthy psychedelic naive people. And what's particularly exciting for me about this data, particularly the healthy volunteer trial, is that we can see that nature connectedness is robustly enhanced at 6 months following the last psilocybin session. And that's really interesting because you don't really see that in the wider nature connectedness research literature. It only tends to go to 3 months post-intervention. And what's also really interesting about this is psilocybin is bringing about this shift in spite of how it's being used, in the sense that it's not being used in a kind of nature-oriented capacity. It's being used in a comfortable but somewhat nature lacking due to the required constraints of the research setting. So it's interesting that in spite of the setting constraints, it can bring about these effects. So these are just a few accounts of how people may experience this shift in their connection during experience. Before I enjoyed nature, now I feel part of it. Before I was looking at it as a thing, like TV or a painting. You're part of it. There's no separation or distinction. You are it. I felt like sunshine twinkling through leaves. I was nature. I was part of one of the more interesting kind of study collaborations with David Luke and Roz Watts, Alex Irvine, and others. And what was interesting is that we kind of looked under the hood, so to speak, at what actually was changing for people in these experiences, why they are reporting these shifts in connections to nature using psychedelics. And some interesting things came up. So experiences of transmogrification, so mental shape-shifting to take on the form of other species during the psychedelic experience. So in some sense, gaining a wider lens by stepping into the shoes, so to speak, of another species. But by far the most central and primary mediator of change were these experiences of deep unity and interconnectedness with the natural world. One thing to sort of consider here from thinking about nature connectedness is that it's relational. And obviously, modern medicine demands exquisitely pure substances administered at a very precise dosage. But I wonder what might be lost, from if someone's potentially harvesting, plucking mushrooms from the earth or growing their own mushrooms from spore. That's a sort of different thing to being administered a lab-made synthetic compound, in that there's already a kind of relational thing at play there before the active dosing. That might seem trivial, but psychedelics amplify seemingly trivial contextual factors to make them non-trivial. I think when they're considering something like nature connectedness, it's a little more salient. There's also some interesting research that's been published just kind of in the last few years, looking at people's experiences of using psychedelics in natural settings, which is very much against the law here in the UK. It has to be very much done in a tightly controlled research hospital setting. And we're seeing some interesting kind of potential benefits, people reporting feeling more connected to the world, more prone to introspection, happy, positive views, and unsurprisingly connected to nature, and some other positive benefits too. It's also interesting to note that one study looking at different types of drug and people's knowledge and awareness of climate change reported that psilocybin, again, was kind of top of the pile. Psilocybin users tended to be more informed and also have more concern for the shift in the world's climate. One interesting thing that came out of all of these recent studies was this finding. A lot of song and dance is made about the capacity of psychedelics to dissolve egos, and much less about their potential capacity to inflate them. And this finding that people may feel a greater disposition to feel humans are insignificant in the grand scheme of things using psychedelics in nature. It makes me wonder, what are the potentials of using psychedelics in nature? Could that potentially keep people more humble and help maybe keep ego inflation more at bay? Maybe, I don't know, but it seems worthy of looking into. There's also growing research suggesting that people who use psychedelics tend to want to spend more time in nature. And that's not something that's being given that much research attention, but the implications of that are potentially profound. There's a huge body of evidence for the benefits of spending time in nature, benefits to mood, well-being, cognition, various forms of memory and attention, creativity, fluid intelligence, all these things. If a supplement could do half of these things, it would be a multi-billion pound thing. A few years ago, I collaborated with a few NHS psychiatrists and public health officials to kind of make the case for group-based nature restoration actions, possibly something that would work well as a post-psychedelic integration practice. I think there's something quite powerful about kind of potentially rolling up your sleeves with a lot of like-minded people and becoming an active agent of restoration. I feel like this is also a direct line to cultivating a deeper connection to nature as well. So just to kind of wrap up, nature contact, despite all those benefits that I mentioned, is hugely underutilized and overlooked and undervalued as a health promoting resource. And by enhancing people's connection to nature, you can in effect potentially increase their desire for having more contact with nature, which has potentially major implications for their health and their well-being. And so, yeah, and the evidence suggests that cultivating a deeper connection to nature is a pathway to a healthier, happier, more meaningful life. And psilocybin is not necessary for that. Psychedelics are not necessary for that. And they alone are not sufficient to push back against the scale of disconnection at play, but they may help. We need as many positive tools, options on the table as we can muster. I think it's worth just reflecting on Albert Hofmann, who's obviously one of the grand architects of the modern psychedelic resurgence. He was a lifelong nature lover. He had some formative mystical experiences in nature in his childhood days that propelled him on a path that led to his work on plant and animal chemistry, that then led to his discovery, creation of LSD, his isolation of psilocybin and its synthesis. And he came to feel that the capacity of psychedelics to reconnect our nature-alienated species to the planet was one of the most important fundamental properties. And reflecting back on his long life at the mighty age of 101, he said, alienation from nature and the loss of the experience of being part of the living creation is the greatest tragedy of our materialistic era. It is the causative reason for ecological devastation and climate change. Therefore, I attribute absolute highest importance to consciousness change. I regard psychedelics as catalyzers for this. Thank you.
That was absolutely lovely. I think we've got time for one question, Sam.
Sure.
I'll say anyone's not burning your house. Only if it's absolutely burning. Clearly burning in the back though. Go.
Yeah, all right.
Yeah.
Yeah. So I just had a great one for what you said. It was really, really interesting stuff. Thank you. So,
Thanks.
so one of the main things in your research that I've always found the most interesting is the fact that in some cases, like the psilocybin, the new nature connection is a intertextual. So regardless of the place they take stuff from it, they feel more connection with nature. I just thought that must emerge from a kind of changing one's interoception rather than interchanging one's ideology. Because if we're suddenly noticing, maybe personally suddenly noticing that there are karma in nature and therefore that. Whereas when anthropologists report animistic beliefs in indigenous and syncretic religious movements, that's a kind of ideological shift that's happening. They're talking about the river people before they're going to things like that. So I guess my question is, would you are there other ways of distinguishing between a contextual, a purely shrunk interoception, like all data connection, and contextual? Are there other ways in which you could look at that?
Yeah, no, interesting, rich pickings then. I like, so personally, yeah, it does seem that the psychedelic like psilocybin can bring about this shift, even if there's not much in the way of nature going on. And particularly in these modern trials, people are mostly lying down with eye shades. They're not really sort of noticing the external setting, even if there might be a bit of artwork or something or photography in the vicinity. But yeah, it's interesting what you're saying about interoception. I mean, we know from the research that if you take psychedelics in nature, it's obviously going to play a big part, that external setting. You're going to be more connected. But I think part of what's happening is we are obviously nature. And I feel like on a strong psychedelic experience, you're going inwards, you're going into your inner nature. It's nature all the way down, all the way up, outwards, inwards, sideways, whichever way. So, but I think there's definitely a case to be made. Bringing more nature into the clinical space. We can't yet take any more out of the clinical space. But I have to chat further.
You bet.
I think it's that what psychedelics do, I'm afraid the image I can show you because it's true, but psychedelics destroy the default mode network. We spend most of our life being taught not to be part of today's share, where the default mode drives the way we think. And we have Western society has driven us into this singular, atomistic way of thinking, which is all internally focused, some for good, some for bad. And what psychedelics do is break that down for a period. And obviously, for some people, it goes back, which is great.
Okay, so now we have our third speaker before the break. Professor Celia Borden, who heads a big research group at XUU. She's just up the road, folks, so I'm guessing quite a lot of you are local. So you kind of have an expert on your doorstep, which is very cool. She's also a professor of psychopharmacology. And she's exploring the combination of psychological and pharmacological treatments in substance use disorders, of which, there are so many and so hard to treat. She's also interested in non-medical use of drugs such as ayahuasca, MDMA, and psilocybin. We've heard all about those three already. She co-founded the MSc in Psychedelics, Mind, Medicine, and Culture at the University of Exeter. And founding an MSc is a massive job. So everybody very grateful to you for having done that. So we can point our students out. And also founded the Exeter Psychedelics Interdisciplinary Centre, which is growing by the day. She lives right about here with her family by the sea in Cornwall. And she's very humble.
Thanks, Jane. And co-founded the Exeter Psychedelic Centre. But yeah, it's great to be doing a talk so close to my house. So thanks very much, Angela, for inviting me. I'm from Exeter. I can't say something like that, obviously. But yeah, and I'm really delighted to be here actually talking about some psychedelic medicine going on here in Plymouth. Obviously, I'm not doing very much. There's people in the audience who are there, Nicole and Flora, who are actually doing the work of this as a therapist in Dover Hospital. So I just explained about doing talks about this, but they do the real work. So yeah, unfortunately, it's ketamine I'll be talking about. So after Sam's lovely talk with nature connector, so ketamine is even sometimes like a bit of nod as psychedelics. So I thought I'd talk through a little bit about ketamine and some of the contradictions of it, and maybe I give you a bit of background to why we think ketamine is a good medicine. One of the reasons, obviously, we started working with it is that it's legally available. So it's a Schedule 2 medicine, so we can use it without special licenses, and it's used all around the world in hospitals. So I mean, it really, so one thing ketamine is, and people think of, and actually, when Sam was talking about the origins of drugs and how that has an impact on their kind of relation with them. And ketamine was synthesized back in the 60s as an anesthetic. And it's a really good anesthetic. It's on the World Health Organization's list of essential medicines. It's used in hospitals all around the world every day. And it's got really good analgesic properties, anesthetic properties, and it's really good because it's quite safe acutely. It doesn't slow your heart rate when you're breathing. So that means it can be used in things like developing countries where people don't have equipment to maintain airways. So it's a really important anesthetic. Its clinical use was limited really by the effects to make it interesting to us. And that's because people are coming around, and they started using ketamine. People are coming around from ketamine anesthesia. They reported quite weird things like out-of-body experiences, being very confused and delirious, and that limited its really widespread mainstream clinical use, but made it unappealing from a psychedelic sense. So yeah, so it is also that we might be surprised by a plant medicine. So weirdly, although it was synthesized back in the 60s, only 5 years ago, it was found that there's this fungus that will be anesthetically appealing as, say, the fly agaric or the liberty cat. This fungus, the Ponchonia Plantatus phosphoria, which is basically, it's a fungus that nematodes off, and it's used plants of it. It's kind of like a guardian plant against pathogens. It was actually found that this secretes ketamine. And also ketamine, some argue whether it's a psychedelic. It doesn't work as the classic psychedelics do, as they've covered, work on the 5-HT2A receptor, has a completely different pharmacology working on the NMDA receptor. but its effects are very much, I think, what we might call psychedelic. And Humphrey Osmond, who coined the term psychedelic, actually included nitrous oxide in that class of compounds. Nitrous oxide works in a very similar way to ketamine on the NMDA receptor. This graph here is quite an unusual one, and you probably can't see it from a distance. This is from a book called The Scientist by John Lilly. It's where he charted, it's quite an unusual read. He charted his own use of ketamine, even taking increasing doses in flotational tank intravenously over long periods of time. And I don't know if you can read on the side there, he charts the kind of dose-dependent effects. He talks about lower doses, it had these kind of internal states and this experience of your internal world, and then at higher states, the vain realities, the extraterrestrial reality where people were encountering entities. It's quite psychedelic. And then at higher still, entering the re-network of creation, as you call it, so these kind of units of experiences. And above that was unknown, which sounds quite scary. So yeah, so ketamine, it's both as aesthetic and psychedelic medicine. And people often say, well, ketamine is dissociative. I said, not really psychedelic because it's dissociative effects and anesthetic, so it's very numbing. And, it does have dissociative properties. This is from one of our studies. There's a qualitative study talking to people about their experiences on ketamine. And this person said, my whole feeling of my body disappeared. It was like being an amoeba. I was floating in space. There was nobody. I had no eye. So that is kind of disconnecting from yourself. But paradoxically, so speaking a little to what Sam was talking about, people feel this sense of connection from this kind of disconnection. So as always disconnecting from their own identity, people feel a connection to something greater. So as your own sense of self diminishes, people feel a sense of unity with things around it. And this person conveyed that quite nicely. The sense of what was important was my relationship with the universe and the universe as a whole, and therefore those relationships with people and other entities, nature and the wildlife. People have taken ketamine very nature and connection enhancing. And I was a part of that, a tiny part of that. But that's where I was thinking that I was part of this greater whole. So another kind of contradictory effects of ketamine, it seems to both promote dissociation, but it's really that there's a sense of connection. So maybe to write it off as dissociative, as people have done, is a little unfair. And then recently, ketamine, and this was an article that was written about one of our studies that was published, and saying ketamine might cure addiction and depression. And ketamine certainly has emerged within psychiatry and being established now as a rapid acting antidepressant. So this graph on the right-hand side, when it's left, you can't really see it from there, but this is one of the landmark studies. Only 20 years ago now, Carlos Soares group, and actually the first study was 5 years before that, where they showed, and this is just giving the drug on its own, giving the drug after 24 hours, and there was this peak. This is people with treatment-resistant depression. So really, really depressed people who haven't responded to multiple depressive treatments. Some of them had ECT and not responded. And we see this massive, so in the whites are people given ketamine, and the black lines people on placebo. And we see this dramatic reduction in symptoms. And they peak about a day following ketamine, but then gradually they return over 7 days. And that's what we see when the drug is given alone, so as a standalone treatment, as it's been rolled out somewhat within psychiatry. And it has these amazingly rapid effects than antidepressants. They're very different from traditional antidepressant treatment. Steve was talking about drugs like Ketamine that have taken 2 weeks to work. Ketamine works immediately. And yet the effects are not long-lived if the drug's just given on its own as a standalone medication. So ketamine as a cure potentially for addiction. But another side, and this is another paper that I published, it's a confusing headlines from 2 different studies, which is the Sun. And obviously, they actually reported the details of the paper on. We've been doing some work with people who take a lot of ketamine and who have really problematic use. And this was a paper we published this year with Bexardin from Museum. And just, again, they've taken out one of the grades of people. We have a qualitative, quantitative element with someone said it's a heroin of regeneration. And certainly we have seen, so just this week, well, over the last few months, the ACMD, which they used to be part of, are reviewing whether to increase the status of ketamine to class A. And what we can see, in relation to that, is that there's been a dramatic increase in the use of ketamine. So this is from 2006, and they're positive when classified under this Use of Drugs Act. It became Class C, the use increased, and it became Class B in 2016, and the use has doubled amongst young people. Maybe showing that drug laws don't really work, as drug science has been saying for some time, but now no doubt it will become Class A. It's not that those two things are linked, it's just showing that it's not effective as a deterrent. Also, that related to this increase in use amongst particularly young people, 16 to 24-year-olds, we're seeing in treatment services an increasing number of people presenting for treatment for ketamine. It's still quite low compared to all other substances, but definitely a much greater. I think it's increased about 140% the number of people coming forward for treatment. And really for these young people, some of the symptoms of ketamine problems are really, really severe. And I won't talk about that today. That's a QR code. I've gone a bit QR code crazy. But actually, when we speak to people who've got really problematic ketamine use, this study we did was around 300 people taking about 2 grams of ketamine a day. And a lot of them are having, I think 60% of our sample were having really serious bladder problems, really serious pain that then causes them to keep taking ketamine because anything that whatever is ketamine. So yeah, there's some really serious consequences in these people. So ketamine has this kind of paradoxical, potentially used as a treatment for addiction, but also it can cause it. And the consequences amongst those that do develop a problem with ketamine are really serious. And then we have, that's as if ketamine didn't have a bad enough image problem. Then there's things talking about how Elon Musk is like the host of both ketamine. And talking about his ketamine use, he says he takes it for depression, but he seems to be taking it quite a lot. And a lot of his very unusual and paranormal actions could be related. Potentially someone has suggested to his heavy ketamine use. And this is why ketamine's got this kind of confused image, I think. On the one hand, the kind of dirty drug also is the savior of psychiatry as well, as a rapid-acting antidepressant. This is another, so I'm just going large on the media. It's another one we published our paper. This is the image for some reason that the Metro shows, which is a horse-headed man snorting ketamine with a box of breakfast cereal. But on the top it says, "Could ketamine cure alcoholism?" And it's a really funny messaging, basically. But I think maybe a more sensible way to look at ketamine is to use this notion of a pharmacon, which is popularized by Derrida, but actually dates back to Plato, I think, is the idea of something that can be both a cure, a remedy, and a poison. And I guess in this time of great polarity, basically, it sort of invites us to inhabit that position of both and, and that's what I say with ketamine. I mean, we keep that in mind as I now talk about our therapeutic use. And the ketamine really seems to really exemplify this notion of a pharmacon. It's both synthetic, but it's also plant-based. It's an anesthetic. It's a psychedelic. And it's also potentially a cure for addiction and a cause. So I'm now going to talk a little bit about the use of ketamine, and this is the study the work that we're running here in Plymouth. Just to talk about, our reasoning behind it. So we think ketamine might work with people with alcohol problems in 3 different ways. So on different levels, really, we could speak about this. So we're talking a really fundamental brain level. And again, thinking these changes can be positive, but they can also be negative. So this is something called neuroplasticity, which can be a really positive thing, just shown to be correlated with reduction in depression, but also is something that's changed in addiction as well. But this is one of the landmark studies with ketamine, which basically shows, so these are spines on dendrites. So they're like the sort of fingery tree-like structures of the angiotrophic neurons that make connections with other neurons. And basically what this study is showing, so this is animals, that if you stress an animal, so these are the little spines taking off, and if you stress an animal, these reduce. And that's what we see, these kind of reductions in mental health problems and addiction. But actually following ketamine, 24 hours later, peaking when the antidepressant effects really peak in ketamine, we see this growth of these spines, enabling these neurons to make new connections in the way in the brain. Then going, on a more psychological level, another way we think that ketamine might work in treating alcohol problems are these rapid antidepressant effects. And obviously the two things are linked. But ketamine sound licensed as a rapid-acting antidepressant and not alongside therapy, but it's licensed as a standalone treatment in the intranasal form of ketamine. So this is S-ketamine. Exists in 2 kind of optical isomers, and Janssen and Janssen have patented this one and developed this intranasal ketamine device, which has started to be used by recreational users who are snorting ketamine. This actually created a kind of harm reduction around ketamine use, which are unintended side effects. But this is now, and it's quite expensive to prescribe, and so I say recommend it currently because of all the kind of development work that went into it. And it's a lot more expensive than standard ketamine, but it's out there. We think that actually, in alcohol, people with alcohol problems, depressive symptoms are really predictive of relapse, because when people stop drinking, it creates this whole vacuum in their lives, and that then can lead to people to go back to drinking. So one way we think that ketamine might work in the treatment of alcohol problems is that could produce these kind of antidepressant effects at a time, a really kind of risky window post-detox. And the other way, of course, we can talk on the kind of brain level, and then also, like a sort of psychological and depressive symptoms level. But also the changes in the experience that ketamine produces for people taking it are quite extraordinary. So people have described it as a kind of time out from the unusual state of mind. So it gives people a break from their narrative selves. Like the experience of ketamine, you can sort of start to drift away from things. People kind of sounds gets stronger and quieter, and then start to sort of fade away, and people start to disappear, and people get the sense of kind of floating away from their everyday self, which gives them a new perspective from a kind of different observer vantage point on their experience. And one person described it as standing in the garden looking at the house that was themselves, being able to see the rooms from the outside. And that's sort of our patient. So it seems to give people that different perspective and a kind of break. And with that, and it gives a kind of freedom. People have talked about sort of freedom from being really attached to your thoughts and attached to your pain. And this is something that's sticks with people a lot in their everyday experience when they're deep in addiction. So it gives them a kind of break, even ability to take a break and get out of that kind of rut of thinking. Related to the default data, probably in reductionist terms. So, yeah. So it does. So that's kind of how we think it might work. So it has these kind of neurobiological changes that increase plasticity. Also works with like producing antidepressant effects like Ketamine, and it gives people these really interesting phenomenological transpersonal experiences. But does it work? Well, I mean, when I talk about our work, I always have to talk about Jen Kapitsky, who's really a forerunner of this. He did some amazing work in the 80s and 90s at St. Petersburg in Russia over 10 years, really, giving people, both people with alcohol problems and then heroin addiction, ketamine, large doses of ketamine, and they were inpatients. And his results with alcohol were extraordinary. So they had group psychedelic therapy. He started out using ketamine as a kind of aversion therapy, actually. So he thought he could use it to make the experience unpleasant. And he was doing things like wafting vodka under their noses to try and associate an unpleasant ketamine experience with alcohol stimuli. But then he found that actually it was these kind of transpersonal, almost euphoric, and the psychedelic type experiences that the people who were having those were reporting to be related to their recovery. So he switched his technique, really, and started using ketamine psychedelic therapy. And this is grounded in the work of Stanislav Grof. And yeah, he had amazing results. He found some people were really serious problem drinkers, inpatients to Russia. And he found that they've given the ketamine therapy compared to a group who weren't. So it wasn't a controlled study. They weren't allowed to, because I asked him, do you have people dropping out of the study? I was like, well, they didn't drop out. They were inpatients. They didn't have the normal rules of a clinical trial, let's say. But he did have these amazing results where he showed a 40% reduction in relapse at 12 months following this treatment, which is huge in substance use treatment. Is one of the biggest effects of much later than any of the treats we have at the moment. And similarly for heroin as well. So we thought we'd take that study, really kind of bring it into a clinical trial setting, and we made some changes. So we was using a very quick psychodynamic therapy. We thought we'd use a kind of evidence-based therapy and settled on mindfulness-based relapse prevention. And so combining that with ketamine, as it seemed to be, and I don't know if it's the phone therapy at the time, but there seemed to be something about the mindfulness state that fitted with ketamine. And not to say that ketamine makes you more mindful, but the experience of the drug it provides this experiential stepping stone. So this was our first study, so we did a phase 2 study where people would come in and gradually build a relationship with the therapist, and they'd have a kind of phone call, a pre-screening phone call, and then they come in for a screening session, and then have support calls as they cut down. So people are abstinent when they start the study, and then they'd come into the treatment phase, the themes have got all a bit mixed up here. We've lost a session off the top. So people come in for a session of therapy, and that's the mindfulness-based relapse prevention. And then there's some kind of preparation for the ketamine infusion. And they'd have a ketamine infusion, and they would come back then 24 hours later and receive another session of therapy. And we thought, by crude terms, that session would be at the time when we see this peak neuroplasticity in the brains, where people are most able to learn from these new techniques and skills that we're teaching them in therapy. And then they would repeat that for 3 weeks. So people would come in, have a session of therapy, an infusion, and then another, and then go home and then come back the next day and have another session of therapy. So they do that 3 times, having a total of 3 infusions, then have a final session of therapy. And then we followed them up at 3 and 6 months. So sorry, the top and bottom of the interactive here. But yeah, just to talk about the treatment setting. So this is one of the nice communes in the RDUH and exercise. So I know the room in Plymouth does not look like this. I can see Nicole, but I'm laughing. So because we're running our study now at 9 sites across the UK, there's quite a difference. And it's running all in NHS treatment sites. So this is one of the ones that we aim to use for ketamine. And this is what we want to use, really. Speaking a bit to what Sam was saying, you want to kind of have a plant in the room, which is very difficult under connectionist policies, to get that cleared, and you need kind of white clean cushions and things to try and make it soft with soft lighting, similar to a standard psychedelic setting. And so we aim the empirical route really for allowing hospitals to even think about this sort of. But yeah, to have that kind of cocoon-like environment and try and aim for people to not have a lot of distraction. People have headphones and eye masks if they want, and we aim to, the therapist is there. And I think it's quite a tough job for them. We can ask them because they have to switch from this very kind of directive. The mindfulness-based relapse prevention is quite, there's elements of mindfulness, but also quite concrete relapse prevention. Either way, when you're sitting with the person, is a very kind of non-directive and just a kind of steady, attuned awareness and presence that we ask for people to have during that experience. But yeah, so this is something I like the setting. Should be like, I think the one in Sussex is the nicest one, right? I don't know. I'm thinking of that. But yeah, so, and then So people, that's the space that people had their infusions in. What we found in our first trials, this had 96 patients in, and 4 groups. I know we don't have much time, so I don't want to go into too many detail. But ultimately, what we found, had a group that had ketamine therapy, and a group that had ketamine and just education about alcohol, a group that had placebo therapy and placebo and education about alcohol. And we found in 6 months, the greatest abstinence from alcohol was in the group given ketamine therapy, which is what we hypothesized. Then ketamine and education, then placebo and therapy and placebo and education. And we found other positive effects of the treatment. As you might imagine, liver function had improved because people had stopped drinking and craving for alcohol had reduced. And at 3 months, although these effects didn't survive to 6 months, we saw reduced depression, anxiety, and increased quality of life. So that's what we're taking forward. We also looked at ketamine use following the trial. So I was very keen in a clinical trial setting, you can really keep an eye on people in a way that you can't when these things are rolled out in the field. So we wanted to include, because ketamine use is so prevalent now in the UK particularly, include people that had used ketamine in the past, not have problems with it. But we did find that occasional ketamine use reported during the trial spontaneously by participants, but there was no difference whether that happened in the ketamine group or placebo group, and none of it was problematic in that sense. Another related to what Sam was saying again, feed something that came out of our qualitative work, where the participants reported as kind of key in their recovery as these increased feelings of connectedness. And this isn't specific to this work, this is something we see across recovery in general, and it's an important thing. People have talked about addiction as a disorder of connection, simply about the drug. But people, so these are just a couple of reports from participants in this trial. The sense of oneness that I felt and the sense of moving away from focusing on the worries and the small stuff is helpful in terms of improving my relationship with outcome. So as it's showing essentially we're all connected. There's this connection between things, people's things, to bring us out of the prison of addiction. People talk about being in an energy format. Sometimes around ketamine, this is relatively high dose ketamine, so people often feel that they've mustered into things and they're part of the fabric of the universe. And then these participants at least were resting that experience as part of why they recovered or why they just stopped drinking. Oh dear, the side of me drowned again. So we've lost a bit off the top. But this is our phase 3 trial that we're running at the moment. So yeah, right, yeah, that's true. So yeah, this is the one that's running in Plymouth right now. So it's a similar therapeutic paradigm. So we have those 7 sessions of therapy and 3 infusions of ketamine. We've added some bits in, which I'm quite excited about. So at the end, so people are followed up to 6 months, and then they can enter into a peer support integration group, which is something that came out of the first study. People really wanted to talk to persons who had similar experience in, and we haven't done that because that wasn't really done in this space. So that's something we added in. And we're also following people up to 12 months. So yeah, it's an ongoing at the moment. It's running at 8, but it's just becoming 9 sites across the UK, including Plymouth here at Derbyshire Hospital. I think we've got 101 participants so far. And we're aiming for a total of 280 by the end of next year. So yeah, that's exciting. But also a lot of work to be done. But yeah, it's great that this is funded. This is a phase 3 trial funded by the NHS with support from Sovereign Therapeutic. And if it gets through this stage, then it's something that hopefully will be able to be available on the NHS. So if you're interested in finding out more about the study, there's a QR code that takes you to our website. And yeah, just to finish really, is thinking about this notion of the pharmacon again. And it doesn't very much seems to be that like inhabit sort of these spaces. So some of these effects that people experience that actually can bring them out of addiction. So a sense of spaciousness and the kind of distance from their problems that gives them this new perspective can for some people taking up the different kind of intention, be in form of bypassing. People take it to numb themselves. So as with all psychedelics, really, like ketamine's no different, and the context and the therapeutic container around the drug is really important. And I feel interested in that, to be researching both these areas. So it feels like you're able to keep an eye on these things and have an idea of what's going on in the addiction world as well. And I wouldn't be doing this stuff if I thought everyone was going to get addicted. And actually, believe very strongly in these contexts, even like this, with the intention of healing, then people don't go on to get addicted. But actually, if you take it for a different motivation in different contexts, that's where the rest lies. So that's something I'm hoping to do some work on. Oh, yeah, so I would say, I don't know about that. I was thinking of more culturally specific ways to explain pharmacon. It's like a farmer's gone. So there you go. That's my weird little Cornish devil joke again. But yeah, thanks for listening.
For years to go into our firm, we sign up to really only to just go balance. It's the honest truth. And that was my reality as well as a younger man. And a younger, angry, violent man. I joined up to parachute regiment because they were the ones that lived in a bed in Iraq, and that's what I wanted. And I found that to be truly familiar with my colleagues. When I went to Iraq, I saw indirectly some of the difficulties that you see in conflict zones, but it wasn't until I got to Afghanistan in summer 2000 that I learned to be really careful for what we wish for, because I wished for a real war experience. I wished for contact with humanity. And it very quickly, I learned that lesson, which we didn't get for what we wish for. I did come to my career, my loss 16 people, not all recover, but the summer of 2008 was particularly difficult. For me, was, wow, one of the greatest times of my life was absolutely my strangest people in my life. And I found it very hard to cope with that moment. But when I got home, I thought, actually, I'm not getting out of this relative achievement. So I felt great to be honest. I was in a really loving relationship after a very difficult divorce that been a few years before. And I still had time really love with my wife. But I said, yes, new types of experiences. I think I might still like it. Well, I began to feel certain feelings and show certain symptoms. The partner that I was with at that time, she did pretty enjoy I spent a lot of time, part of work. And I remember after I got home, I was having such a bad time. Sat in the bar, just got into the bar, had a drink, wasn't drunk, just had a drink. I even remember laughing, sitting there laughing. Took me to her thinking, this is fantastic. She adores me, I'm this well captured. I've survived. That's enough. Life is great. And then my body started to cry. And I said, advocacy. I wasn't emotionally upset. I wasn't upset in any way, but my body was immediately with the violence. And I saw her looking on. And I thought, this isn't this time now. So I took myself off to the top and so just looking upstairs. There's something's not wrong. Now this is highlighting. I've been hiding it. It wasn't long before after that sweating in head. If I stood in place long enough, I know that I could sweat. A river of sweating miles from you. With a finger, like the creative slam pulled. If I took that, they wet inside, it just the sweat, so my body was under so much pressure that I was completely capable. My mental health wasn't actually stuff that I was having is really quite worrying physical symptoms. So I thought, I should probably do something about this. And I went down and eventually that urinary disabilities it's the same thing you go to a GP. Or I said to them, having showing these symptoms in themselves. Well, you've got two options. You could talk to someone, you can do these SSRIs. And I thought, well, Lord was sure. Took the SSRIs, really didn't get along with that day. Dulled my experience of one, which was worse than feeling pain. Talking to someone, I went through 3 therapists, I just it. And the other felt that they were credible in my picture, which is not. I'm sure they'd have highly still, but in my eyes, I just didn't believe that. I didn't find them credible enough that they could help me. And anyway, time passed, CT continued. I went back to GP, said I know you worked before, but let's give it another go. Is there anything else? If I've made really, I've had to give it another same I did it 10 times. And then I just thought, by then I think I had a ton of confusion, my meetings, everything. So I've done everything I had a dream of doing. I had a wonderful time. I managed very fortunate to leave the military on Friday. And then Monday following, I went into the doctor job he ordered, which is in investing based on Manchester, and all of it. I thought, my reasoning for taking that job and getting so excited, besides the money, is that, all I really need is just a calm place to work. Because the military is chaos, and everyone's on the scent. It is hellish. It's hellish. And part of me thrives in that. I had usually. It did not help my symptoms. It did not help my symptoms. So it's really bad, you're paying like many hundreds of pounds for them. It's a bit sick, so I'm just destroying in one gully. It's just destroy everywhere. I can't shake people's hands because beforehand, doing this. So I was really, really struggling. I was actually a crisis agent because Well, like, that's the position I was in. Because they all thought, well, it just was pretty calm. Because I was. But physically, my body was saying, you got more. I was feeling gentle. One morning, I ran this crisis management meeting. And unfortunately, I got in just before a phone rang. You may see it, someone in the said, yeah, have you seen the person laying on the roof? JP Morgan Love has is a big tower, but then it has a much lower, another building attached to it that has a lower floor. Someone was laying on the floor, and it turned out that he did suicide. And so I didn't shoot anything. And I just thought, that's my role. I have to help them. And I thought, oh, it's one thing signing up for them and join the parachute graduate. Sure, I've lost friends, very. Me in London, I'm a Londoner, but it's just what I'm saying. I'm not here to do it, to really push the fucking forward. Just actually do it and to take them. I also didn't do talking therapy or SSRIs here. I did another day to disability. And I took the it's very inspiring and sharp. And I didn't really know what else to do because you keep asking for help and they keep saying, well, to talk to someone, it's good for it. Which I agree, it is good for you, but it doesn't touch you in this kind of thing. Does it really? You might, doesn't what you does it really touch complexity, or complexity? And but then, two friends of mine who both live in LA, but separately contacted me. And they said, Keith, I've just been on the trip in Kenya, and I got this thinking about this. And I know what you're going from. I think you should have a religions. Two people in each other message you, very much inside the same, very happy in some amount. It's very deep. And I said, sometimes you got to follow the signs. So I said to one of them, I was like, okay, how do I do it? Can you help me do that? And she connected me to see people being through it. And I went up to JP Morgan, so taking 2 weeks off work, and that's clear. And I flew out there, and I got met off the plane by these two locals who said, hello, I'm really to help you. I said, okay, great, I don't remember what I'm doing, but we got in a car and drove me for an hour, followed the river pretty much, down the one, up the one, we parked the car at this deep and zoning village and got into a boat, went in our boat, further up the river for about another hour, and then parked up in this tiny village. And then they took me up into John to carry all of my drinking later. I was there for 10 days. The three of us had to carry out our drinking water and our food because there was just nothing there. There was a hut that they had by a river. It had banana trees and these big trees. They're not happy to live like that. Fancy PTSD. And they said, that's your turn about is it? Is that a mattress in? I said, oh, great, okay, where are these staying? Oh no, we just go back there. Okay. So what happens now? And I said, oh, a couple of times during the week, the local maestro from the local village that we parked the boat at, we said, all that, he'd take us in. I have to so just you do. I was like, great, but what do I do to you all that time? And they said, well, just had a nice time. And you know what? I really did. Full transparency, I've spent that time mostly naked, sat in the river, fighting monkeys off my bananas and looking at butterflies. And I had a wonderful time. I didn't even take my phone or the camera, so all I have is drawings of the scenery. You found you my very clever action, crayon drawings. I even eat crayons. But then, on one day, I think it was the Tuesday, I was sat on my pool. And someone came looking up. No one came looking up the path. So this guy comes up the path, and I think, oh, this must be him. But he didn't really look like a shaman. Didn't have any. He had some jeans and absolute batik and an old t-shirt. I know several maestros now. They all seem to just have batik jeans and old t. Yeah, this way. He was carrying a 65 centiliter poppet. But it looked like it was hot in the mud and it used the decos. And I've fed this to the wild. And I didn't really speak Spanish that well, but a year ago, he had no English at all. So I just kind of looked at him and I said, what do you want me to do? He said, just lay down there. Okay, great. I just undersold you, but I just, you won't tell me that. I sat down and laid down. He said, we poured it out, and anyone that knows what I was saying, he said, it doesn't even about anything about the drink. Let's keep that. Try to lay down, listen to my, listen to my house. It's not simple. And I have a wildest, most beautiful bitterness my life to and I walked out of that jungle at the end of that 10 days. Everything changed. Everything changed. And I stepped out from under this kind of hippie life. Everything is so new for me, and things closing, and love feels like the impossibility for me to love myself, to forgive myself. I know myself better, I understand myself better, but this can't be only for me. And I so many of my friends that are suffering from my story. How the hell do I get then access to this as well? And so that was pretty much off it. It took me 8 years of integrating before I get myself into a real position of strength, not just going from my own human place, a position of strength where I felt like trustworthy enough, knowledgeable enough, whereby I could introduce people that I cared about into these medicines and how these opportunities. But by then, I realized that actually an organization is by the form to about that project, it's the UX. Well, he said, don't believe they will just you take large. So, the bad times, like, this is take your the brand new, all of your hard work and just wrong with it. And he said, yeah, go for it. We're very well aligned, I trust you. So I thought, okay, well, you can go there. The first thing that happened after I started making IT, that mobile network, but you could be in touch with Robin Carhart, and Robin, this is exactly how it happened. The first person I ever spoke to was Robin Carhart. He invited me into Imperial's to his team. So the first time I ever spoke about this was in Imperial College, speaking to Robin Carhart to be in his team, trying to which is addictive. But from there, it snowballed this habit. And so, what is it? Actually, I did the one without it. For our class, we help military veterans, British military veterans, and emergency services personnel illegally access secondary medicines. We do that by facilitating retreats in the regional Alaska, or we use subsiding truffles in the Netherlands. Every time we do one of our retreats, and that we don't just retreat, we offer a program, 9 million 5 days, which is over. That we use the 2-week preparatory phase beforehand, but it's not enough for it's a risk to. We have a week on retreat, and then you have 6 weeks of immersion afterwards. Regardless of what medicine. On every retreat, we did that. We take it as an opportunity to do that observation and research. So not clinical tongues, just and so far we've looked into interesting. We've looked into effects of suicide and related brain injuries. Just got back 2 months ago from our first suicide injury focus on gambling. Gambling addiction, is not one of this another thing. And we've just seen the most remarkable results. I'm not a data person, even though I know it's very, very useful. But I just love watching people. I get to, and this is the most meaningful work I've ever done in my life. I was so committed to my life in contribution for the whole identity. And yet, this is the most meaningful work. The greatest thing in my life I've ever achieved. And the transformation, actually, I don't actually believe it's a transformation. I don't believe in change of the person. So no brain changes, honestly, but I don't believe that we change to people. What I just believe is that the assets all very time people should love it, pushing the villains, but life is just that our fate. Things just get very seriously to our defense mechanisms in fun about truth shadows to protect us.
those barriers. We need protecting for this life experiences. But I found this psychedelics feel way because we used to be to like think about it. So instead of change, we just become close to English clients being in the lessons, which is something to write on forgiving in action. And then thought I would be simply about these things instead of doing background these words. Yeah. So in addition to my own psychedelic offering these opportunities, I didn't realize there was a catching it. So my 20 minutes is up. I'm just going to take another couple of minutes. So that's what we do. It's why we do. Well, great team, by the way. It's not just me. This is a whole team around my own stretch and actually this with one team of volunteers, 5.5 years volunteering, very young team, pretty much not enough. That's what we've done. What are we doing? We hope to start a compassionate access campaign, GR campaign, to start a compassionate access program where our British community with veterans and emergency services personnel no longer have to travel home to access their services. We shouldn't have to. We can do that, and the right part probably will always up for that, because sometimes these things can be fear-related, can be addicted to those spaces. We shouldn't have to, and we do have to, as an elite status in this country. The drug policy in this country, as I've said before, is bizarre and worse than what eternity. So yeah, I'm really hopeful to get this PR campaign along the way. And it's really intriguing recently. It's just very fun on the drug science podcast. The most recent one was the sleep paramedics that for which people don't themselves. They came through they're the latest participants that are much leading to achieve incredible hands-on attitude with them, remarkable experience. And sometimes sometimes it's my worry where it is people that jobs. Sometimes the psychedelics might say, oh yeah, but don't do that job anymore because it's harmful to you. But what we actually found in these paramedics is that they were suffering from burnout, from emotional and compassion fatigue in their professional work, but they loved what they did. They loved it. And what was found is that they couldn't wait to get back to work, which is the same, right? And especially in the trauma that these people experience, and also on a daily basis on the chipping back. Which has these people just desperate to get back to work because you love what they do, so they've got all this compassion back to give again. I think that's a hard part, let alone all of the other just breathtaking results that you see now. Still out of fortunes. I really do think I've done that time. So thank you very much for listening to me.